Welcome to the weekly Neurology Deep Dive. This week, we're going to be looking at the international consensus guidance for the management of glucocorticoid-related complications in neuromuscular disease from the Muscle and Nerve Journal. As always, this deep dive is for educational purposes only. It's not medical advice, and it's not a replacement for reading the full paper. What we're trying to do is distill this dense guidance down to what's most useful day to day.
Yeah, just trying to give you
The
key recommendations without getting bogged down in all the details.
So glucocorticoids, powerful tools for treating autoimmune neuromuscular disorders, but those benefits come with a cost. This guidance is here to help us navigate those potential side effects.
And one of the first things I noticed is it emphasizes that team approach, not just the neurologist's responsibility. It's primary care, endocrinology, other specialists.
A true multidisciplinary effort.
Yeah.
What are some specific recommendations in terms of that general care and screening process?
Well, for starters, the guidance stresses clear and thorough patient counseling, making sure patients really understand potential side effects before they even start treatment.
That makes a lot of sense.
Yeah.
Setting those expectations up front.
Absolutely. Along with that, the guidance highlights the importance of regular monitoring, keeping an eye on things like blood sugar and blood pressure, especially in patients who may already have some of those issues.
Definitely things we're already watching for, but the guidance is really emphasizing that proactive management.
Exactly, and in some cases, they recommend considering prophylactic medication for peptic ulcer disease in those high-risk patients, again, anticipating potential issues, and stepping in early.
I like that proactive approach. Anything else we should be looking for in that initial screening?
Regular eye exams, particularly for patients who are on long-term glucocorticoid therapy.
Makes sense. Catching any eye-related side effects.
And they're very clear about tapering glucocorticoids slowly when the time comes, no abrupt stopping.
That's a point I've heard stressed time and time again. Why is a slow taper so crucial?
Because suddenly stopping glucocorticoids can throw the body's hormonal balance off.
And that could lead to a whole cascade of problems.
Precisely. Speaking of potential complications, the guidance spends a lot of time talking about bone health. Glucocorticoids, even at low doses, can increase the risk of osteoporosis and fractures.
So what are the recommendations for mitigating that risk?
First and foremost, screening for osteoporosis should start at the beginning of treatment.
Early detection is key.
Absolutely. If someone's going to be on glucocorticoids for more than 3 months, regardless of the dose, the guidance recommends preventative measures.
So duration is just as important as dosage. When it comes to bone health, what kind of preventative measures are we talking about?
Well, lifestyle modifications are a big part of it. A balanced diet, quitting smoking, limiting alcohol intake, and regular weight-bearing exercise. All crucial.
Good advice for everyone, really, but especially important for patients on glucocorticoids.
They also recommend vitamin D supplementation, around 600 to 800 IU per day.
To help with calcium absorption.
Right, and calcium. The guidance suggests aiming for 1,000 to 1,200 milligrams daily through diet or supplements, unless there are contraindications.
So a multi-pronged approach to bone health.
And if those measures aren't enough, the guidance says talk with a primary care doctor or a specialist about prescription medications for osteoporosis.
So escalating treatment if needed.
Vaccinations.
That's always a complex conversation. For patients on immunosuppressants,
The guidance emphasizes close coordination between the neurologist, the primary care physician, and ideally an infectious disease specialist to develop a safe and effective vaccination schedule.
so a real team effort. What specific recommendations stood out to you?
Well, live attenuated vaccinations are generally off limits for patients on high doses of glucocorticoids, meaning 20 milligrams per day or more of prednisone equivalent for over 2 weeks.
So that's a pretty clear cutoff. When is it safe to give those live vaccines?
They recommend waiting at least a month after stopping or significantly reducing glucocorticoids.
Timing is everything.
It really is. Now, if a patient isn't on glucocorticoids yet, but needs to start them, the guidance suggests holding off for 4 weeks after a live attenuated vaccine and 2 weeks after an inactivated one, unless it's an emergency.
Give the immune system time to respond. What about the herpes zoster vaccine? Any specific recommendations there?
Ideally, patients should receive the herpes zoster vaccine before starting glucocorticoids, if possible. And for those already on high-dose glucocorticoids, they recommend using the recombinant version.
Different approaches depending on the situation.
Exactly. And of course, the guidance strongly encourages annual flu shots with the inactivated vaccine for all patients on glucocorticoid therapy.
Standard practice, but always good to reiterate.
They also recommend pneumococcal vaccination for adults between 19 and 65. who are on glucocorticoids for more than 2 weeks.
Extra protection for that age group. Sounds like there's a lot to consider when it comes to vaccinations for these patients.
It is. It's a nuanced area. It requires
Yeah.
individualized decision-making.
Well, we've covered a lot of ground already, but we're not done yet. What's next? On our deep dive into these guidelines,
Let's move on to infectious disease prophylaxis. So when we're talking about patients on glucocorticoids, especially higher doses or longer durations we have to think about, the vulnerability to infections. And that's where this next section of the guidance comes in, infectious disease prophylaxis.
we're essentially trying to stay one step ahead. What are some of the key recommendations?
Well, they start by talking about pneumocystis jirovecii pneumonia, or PJP. It's rare, but it can be a serious lung infection.
So what do they recommend when it comes to PJP prophylaxis?
They say, consider it. If a patient is going to be on 20 milligrams or more of prednisone equivalent daily for at least a month.
And is that regardless of whether they're on other immunosuppressants?
If it's just glucocorticoids, yes. But they do recommend it more strongly if a second immunosuppressive agent is being added to the mix.
So combination therapy warrants a more proactive approach?
Right. Now, for the actual prophylactic regimen, they recommend trimethoprim sulfamethoxazole, or TMP-SMX, either one single-strength tablet daily or one double-strength tablet 3 times a week.
Are there alternatives if a patient can't tolerate that?
There are. The guidance mentions atavacone, dapsone, or aerosolized pentamidine. But you know those decisions are best made in consultation with an infectious disease specialist, taking into account the patient's individual factors.
Bringing those specialists in is key.
It really is. Moving on from PJP, the guidance also has recommendations. For prophylaxis against other infections, for example, they recommend screening for strongyloids stercoralis before starting glucocorticoids in patients who come from endemic areas, or those with unexplained eosinophilia.
Making sure we're not missing that particular infection. What about tuberculosis?
They recommend screening for latent tuberculosis before starting glucocorticoids, especially for high-risk patients. So we're talking about people who were born in or who frequently travel to countries with high tuberculosis rates, or those living or working in settings like homeless shelters or correctional facilities.
Again, considering those individual risk factors.
Yeah.
And what if a patient does have a positive TB screen?
Refer them for an infectious disease consult and treatment before starting those glucocorticoids.
To prevent reactivation. What about hepatitis?
For hepatitis B, they recommend screening patients who will be on a dose of 10 milligrams or more of prednisone equivalent for at least 4 weeks.
A little lower threshold than for tuberculosis.
And if glucocorticoids need to be started urgently, get those hepatitis B and tuberculosis tests done as soon as possible and start treatment right away if the results are abnormal.
A sense of urgency there. What about hepatitis C?
The guidance says, think about hepatitis C screening for patients with neuromuscular diseases who will be on glucocorticoids for 4 weeks or more. But they really emphasize shared decision-making in this case.
Because the risk of transmission during glucocorticoid therapy is relatively low.
Exactly. Now, whether it's Hep B or C, the guidance says patients with positive screens should be referred for specialist consultation before starting chronic glucocorticoids and co-managed throughout their treatment.
To make sure they're getting the most comprehensive care. Is there anything else?
One last thing. They recommend offering HIV screening to patients who will be on 20 milligrams or more of prednisone equivalent daily for at least 4 weeks.
Again, emphasizing shared decision-making with the patient.
Absolutely. And just like with hepatitis, if a patient tests positive, they should be referred to an infectious disease specialist before starting glucocorticoids and co-managed during their treatment.
This whole section on infectious disease prophylaxis really highlights the importance of a proactive and collaborative approach.
It does. It's all about anticipating potential problems and working together to keep our patients safe.
We've covered a lot, but it feels like we've only scratched the surface.
That's the nature of a deep dive. We're trying to take a complex topic and boil it down to its most essential elements.
And these guidelines are certainly comprehensive. It seems like these guidelines are really going to change how we manage these patients.
They really are a much more comprehensive and proactive approach.
But as you said, we've just skimmed the surface. There's so much more in the paper itself.
Definitely. I encourage all of our listeners to take some time to read the full guidance document. It goes into a lot more detail about why they make these recommendations, the evidence behind them, much more than we can cover here.
So consider this your jumping off point. We've highlighted the key takeaways. But the real learning happens when you dig in yourself.
And once you've done that, think about how you can use these recommendations in your practice.
Because every patient is different, and every situation is unique.
Exactly. There's no one-size-fits-all approach. These guidelines give you a foundation, but you have to build on that based on the individual.
And remember, you're not alone. Reach out to colleagues in other specialties if you need help.
That multidisciplinary approach, so important. It's about working together to give our patients on glucocorticoids the best care possible.
This has been really eye-opening. It's definitely changed how I think about glucocorticoid management.
I'm glad to hear that. I hope our listeners will come away with a better understanding and use this information to improve their practice.
It's all about improving patient outcomes.
Absolutely.
And with that, we'll wrap up this deep dive. We hope you learned something, and we encourage you to keep exploring the world of neurology. We'll be back next time with another deep dive into a new topic. Until then, keep learning and keep questioning.